This conference will now be recorded.
Now I'd like to turn it over to Terry Hill, Senior Advisor for Rural Health Leadership and Policy, to introduce our speaker and to get us started.
Thank you, Keely, and good morning, everyone. Welcome to the first in a series of webinars dealing with COVID-19, the rural hospital response. We have a four-part series beginning today with bringing telemedicine to rural facilities, the impact on COVID-19 pandemic. When we put this series together, we thought, what would be the four most important things, given what we know about so far about COVID-19? It's what would be the four most important things we could look at. One of them is definitely telemedicine, and we're going to talk about that today. There's been an extraordinary growth in the number of telemedicine visits. It's now being used extensively for COVID-19, et cetera. So we thought we'd lead off with that. Our next, we have, for this one, we have Dr. Stephan, who is an infectious disease specialist who does telemedicine across the United States, actually. So Dr. Stephan is going to do the presentation. Next month, we have Ralph Llewellyn, who's one of the principals in the consulting firm of Eide Bailly. And so he is a finance expert on this topic. He'll give us pointers and information about how to maximize our revenue and our finance during this really disruptive time. The month after that, we have Lee Elliott, who actually used to work in a hospital in Nebraska, who is my go-to person for anything to do with HR. He's absolutely a master at working with staff, working with leaders, et cetera, and he's going to be looking at staff resiliency, another really key piece here. And finally, in August, we're going to have Louise Bride, who's with the Stroudwater Group, really looking at post-acute care, the area where we have experienced the most deaths and basically the most trouble in terms of providing care for our patients in our long-term care facilities, and basically thinking about strategies that we can use to really address some of this sort of problems that we're experiencing. So that's our schedule. And I, first of all, want to thank the Nebraska Office of Rural Health, who have funded and sponsored this program. Their Medicare Flex program, as you probably know, has responsibility for supporting the critical access hospitals and the rural hospitals across the state of Nebraska. Nancy Johansson and Margaret Bachman do a really good job in that regard. So we first want to thank them. And then also the funding that they receive comes from the Federal Office of Rural Health Policy. My background, the legitimacy I bring to this topic is that I chair the National Rural Telehealth and HIT Coalition that meets about 4 times a year, usually in Washington, D.C. And so we've been looking very carefully at where the whole telehealth industry is going. And it's something that I think I can add to that. I've got about 35 years of experience working with rural hospitals. And I was the founder of the National Rural Health Resource Center that got put together in 1995. And since that time, we have supported rural hospitals and state offices of rural health. Pretty much we have worked in every state, and we are a resource center that I would invite you to come into. It's at ruralcenter.org. We have a ton of resources in there on finance, quality, population health, accountable care organizations, you name it. So I thought I'd start out by just giving you just kind of a quick overview of where Nebraska is sitting in terms of the COVID-19 response, and this is just a very thumbnail sketch. First of all, as we look at the conditions here and we see COVID-19 has not made a very large penetration in Nebraska. It, along with some of the other, particularly Midwest states, have not been hit very hard to date. The other real positive so far is that in relationship to the other states, our Nebraska hospitals basically are standing second in the country in terms of days cash on hand. So that's obviously a very important situation given the need to dip into our reserves during this time of less procedures and all the other financial problems that you folks know full well. But there's another side to that coin as well, and there's some concerns that I think that can be expressed about where Nebraska is in terms of dealing with COVID-19. For one, they're relatively high. The state is relatively high in terms of hospitals without ICUs. The national average is about 61% of all our critical access hospitals have ICUs. And I think in Nebraska, that percentage is closer to 80. And when we take a look at a variety of other factors in terms of Medicaid expansion, other things that are put together by a group called Chartist Advantage, Nebraska actually comes in about the middle in terms of all of the states in terms of its vulnerability to COVID-19. We expect this problem to exist way beyond the next few months. And in fact, one of the other negative factors here is that our growth of COVID-19 cases and deaths in rural areas is now higher than it is in urban. So that's just the rate, it's not the numbers. But we've long been expecting that COVID-19 is going to make its way out to a good part of rural America. And as I said, the Advantage folks have classified Nebraska as being moderate risk in terms of vulnerability. The other thing I want to say is that we have seen a very consistent growth in telehealth. We've seen, and Dr. Stephan's going to talk more about this, but we've seen a number of new codes being put in place. Home care now has new codes. And with the CARES Act, obviously, we've seen a gigantic increase in the number of telemedicine procedures in both urban and rural areas. And let me just give you an example. In the state of Minnesota, where our offices are, although we have people across the United States working in various other states, but in Minnesota, Stratus Health, our QIO, had put together a group of all of the bigger healthcare systems. I think there were 11 of them in the state of Minnesota, tracking the number of telemedicine procedures that were going on. And according to their study, in the month of February 2020, those systems collectively did about 1,149 telehealth procedures every day. 6 weeks later, that number had increased from a little over 1,000 to over 15,000. 15,480, and that's a 1,350% increase, just a super dramatic increase here. And we'll talk a little bit more about this later, but part of what we're expecting here is that telemedicine and telehealth is going to continue to boom way beyond the COVID-19 crisis. And I'm going to speculate personally, my opinion, we're not going to come back from a lot of the at-home visits, the virtual visits, etc. So I think since telemedicine has been such a big part of the COVID-19 response strategy, that this particular issue is going to grow larger all the time, and I think it's going to be extremely important for rural hospitals to understand where they're going to fit into this telemedicine picture. not just being on the receiving end of that telemedicine, but perhaps doing telemedicine out of our hospitals as well. And we can talk more about that later. So with that, I want to introduce Dr. Kevin Stephan, and he's with a telemedicine group, tell you a little bit more about it, called NOD Telemedicine Group. He is somebody that has a terrific background in both infectious disease and in telemedicine, and we've invited him to be part of this webinar to talk about both the COVID-19 situation and also telemedicine. So with that, Kevin, I'm going to turn it over to you.
Thank you, Terry. Appreciate the background and bringing us all up to speed in the state of Nebraska, as well as the opportunity to present on this topic today. It's timely. Everybody's interested in it. All of a sudden, people really, even if they weren't paying attention, they're looking at, should they be looking at leveraging this technology, and how do you even get started if you're not already in the midst of doing it, if you're not familiar with it. And so it is a topic that I think is timely because of COVID, but also because of the way that we have to deliver healthcare increasingly in resource in areas without the resources to have specialists around. And so telemedicine is a unique tool to help us provide high-quality rural healthcare and urban healthcare, but particularly some of the issues that rural areas face. I really believe telemedicine, we'll be here for COVID-19, but really, I think COVID is forcing us to face the reality of how we can help with disparities in healthcare resources and how we can leverage this technology. So I'm excited to have the opportunity to address these topics and these concepts today. As Terry mentioned, I have a background in infectious disease. Currently, I'm the Director of Strategy and Planning for NOD Specialists. We're an infectious disease telemedicine group. The principals are board-certified infectious disease physicians with a long track record of experience taking care of patients. I've enjoyed some recognition by peers. I have a background in the military and was fortunate enough to have some national and international leadership opportunities during that portion of my career. But, some of the topics that are surrounding telehealth are related to the regulations with Medicare, with state boards of medical licensing and those types of things. And it's important for me to say it up front that I'm not a legal expert or a reimbursement expert. And so I'm going to be speaking to these topics from the vantage point of a clinician who takes care of patients on a daily basis. We are seeing that telemedicine status, relaxation of guidelines, the ability to get telemedicine resources to where they previously weren't able to go, all of that is a welcome change. But we're not sure what the landscape is going to look like post-COVID, how much of it is going to be walked back, how much of it is going to persist and even maybe be expanded upon. So I think it's just important to realize that we're in a changing landscape, and we have to be agile, we have to be flexible, we have to keep informed on where the policies are going and where the regulations are. My last bullet on this slide is just basically the fact that to keep it real and to keep it credible, I'm seeing patients via telemedicine on a daily basis, 7 days a week. In fact, this morning I have hospital rounds virtually in a rural hospital in Colorado. This afternoon I've got outpatients that have found us through the internet or our follow-ups from hospital discharges, patients who are seeking an infectious disease specialist for their long-term problems like hepatitis or HIV. And some of these people can't find an infectious disease specialist in their community because of living in a rural or a less densely populated area. So again, every day that I do wake up, the telehealth resource is front and center in my mind, and the fact that we can do things that we couldn't do even 10 or 15 years ago is really, even just a year ago, and when it comes to some of the regulations, is really, I'm mindful of that. So let's talk a bit about how COVID-19 is impacting all of us in healthcare. when you have a pandemic and there's the drain on medical and healthcare resources, a rapid expansion of the cases starting in January in the United States through February, March, really it was taxing our traditional methods of care. People were showing up, and they were either sick themselves or they were worried that they were going to be sick, and they wanted testing. The test kits weren't available. There was a delay in rolling that out. Dealing with healthcare facilities having to deal with this influx of patients that previously maybe wouldn't have sought care, along with their mix of chronic patients with chronic healthcare issues. Those problems didn't go away, and yet somehow we had to have a surge capacity to be able to accommodate the people that could have COVID at the same time that we have the people with the chronic health issues. We wanted to keep people safe, and that was, of course, social distancing, sheltering in place, and that made it very difficult to receive care. I mean, if you think about the typical practice model, coming into a local ER, an urgent care, an office-based practice, and then getting care in the hospital setting as well, these were all predicated on having close contact with other human beings. And so all of a sudden these regulations and these recommendations being put into place regarding keeping your distance have made it extremely challenging to deliver care and to have our medical practice be business as usual. And then, of course, complicating things, unlike influenza where we've got some medications and vaccines, with COVID as a novel virus, we had neither. And so that's really made it more challenging to know how to take care of all the people who have these health concerns. As I alluded to, examples on how this impacts healthcare, and this is personal experience and also what I've been reading, of course, with other parts of the country and their experiences. This surge of patients seeking evaluation and treatment. We've all been worried about PPE. I helped a couple of facilities rework their policies surrounding protecting their staff and their medical providers when there were shortages or potential shortages of vital PPE. They didn't want their frontline people put in harm's way, understandably, and the frontline people didn't want to be put in harm's way, but they also felt that they had a mission and a job to do, and they wanted to be able to show up and do it. But there were questions circling around, can you reuse N95 masks? Do you have to gown and glove and put on a face shield, or what's the appropriate level of protection for the procedures that we're doing? What's an aerosol generating procedure, and how do you define that? There are all sorts of questions that swirl around that. A lot of facilities weren't necessarily designed optimally to be able to cohort infectious patients. I mean, if you have an isolation area or if you had a negative flow area in the facility, those resources were strapped and quickly overrun because there just weren't enough of those types of rooms to be able to accommodate the influx of patients. And then let's face it, you're most of the time you're dealing with knowable conditions, and you have your routine and you have your protocols for delivering care. There's a workflow in the workplace, and all of that was being disrupted, and this austere danger setting was adding a lot of stress to the workplace. And then there was the additional stress that once you left the workplace, you could be contagious and maybe bringing home an infection to your loved ones. And so there was a lot of emotional burnout going on with the healthcare workers, and still is. And the issue is that as the tip of the spear, as healthcare workers, if you become ill, next man up in the military is what we used to say, but who's going to take the place of those people? And if you're in a resource-poor rural area, you may not have an abundance of medical assets in terms of your personnel. And what are you going to do if your frontline people become ill or have to self-quarantine because of exposures to COVID? Those all were issues that were very germane to providing care in the way that we're used to. So Terry mentioned this and alluded to this, and this is something that we thought was going to happen, and then we were waiting for the hoofbeats, and now we're hearing them. Basically, we heard about the urban centers getting hit hard and early. New York City, Washington State, San Francisco, some of the places that there was a real surge of cases early, and now we're seeing a redistribution of the cases in terms of the percentage of new cases showing up more in rural areas than we've seen before, and on on a percentage-wise basis or per capita basis, actually in many rural areas now exceeding the urban areas. And rural areas face challenges that their urban counterparts may not. And this audience, I'm sure, is aware of those. But the lack of hospital capacity, the low number of ICU beds when you've got the really sick patients that need the ventilators. Do you have a ventilator? Do you have staff that is comfortable using the ventilators? Do you have enough ICU beds? The demographics of rural areas are that they tend to be an older population, and even the younger folks tend to have more underlying health problems than in many urban areas. So you're dealing with a less healthy population even at the beginning of the pandemic, and then as the pandemic moves through the rural areas, we know that people with underlying health problems are usually more severely affected by the virus. So one of the things that I wanted to talk about this morning is why telemedicine is such a nice tool to be able to have in your toolkit and to be able to leverage when it comes to providing care in a rural healthcare setting. And there's three major areas. You can rank order these in terms of degree of importance. I think they all are valid, though. And the three big categories that I would say are increasing access, the cost effectiveness of care, because we all have to pay attention to the bottom line as we have a small and finite pie financially, and how we're going to make those dollars work for us for taking care of patients. And then, as you're trying to be competitive with market forces and have the respect of your community so that you'll be a preferred provider of care, the perception is that if you have telehealth, you're forward-facing and you're embracing technology and you're not stuck in the past. So just to kind of touch a little bit on each of these three areas, increased access, the service lines that may not otherwise be accessible. I mean, many of you probably have heard of telestroke or teleneurology. There's teleradiology has been around for years. That was one of the first specialties of healthcare that went digital with the digitization of the imaging. Then it was a natural extension of that to have radiologists around the world be able to read the images, because you literally could read them from anywhere. But a lot of other specialties that are hard to recruit or hard to maintain in a rural setting, or because of the shortage of specialists, they just simply weren't going to be available. And now via telehealth, specialists can really assist in providing care to the same level in many cases as in the urban centers. It allows the patients to remain in their community. When I'm rounding in a rural hospital, I can tell you that every day I hear from the staff, the providers, and the patients and their families how grateful they are that they're receiving specialty care in their community hospital, in their rural critical access hospital. It was inconceivable to them even a year or two ago that would have been a possibility. Typically it would be a long ambulance ride or even a helicopter transport if they needed a specialist, if they were sick enough to need that type of care. The other thing is, because you can spread the resources out and you can have a practice that has multiple credential providers providing care, there's no disruption to this care with PTO or due to illness. In terms of cost effectiveness, let's face it, if you have to recruit a provider and pay their salary, pay their compensation, pay their malpractice, pay their benefits, and all of those types of things, that's expensive. And if you can just purchase the part of the healthcare that you need, let's say you really only need a 0.3 of an FTE for a certain kind of specialty, well, you can get that via telehealth in ways that you probably wouldn't be able to readily get if you're trying to have a brick and mortar practice with boots on the ground. Transportation costs, I mean, those life flight helicopter rides into the major metro areas aren't cheap, and you can reduce that substantially. And I did touch on this whole idea about prestige, and again, it's about image, it's about marketing to the population in your community. I mean, if you can say, hey, we're a leader in healthcare and we're working hard to remain a leader, you've trusted us, with your families and with your loved ones, and now we're doing everything we can to add these service lines so that we can be a full spectrum center of care here in this community. So the geography of my specialty, and which is the one I can speak to the best because I know it the best, there's about 7,000 infectious disease physicians in the United States that are in clinical care, and probably conservatively 95% are in urban areas. You know, you get out 50 miles radius from the major metro area and it really becomes extremely difficult to find a specialist in my specialty. Telemedicine, however, can address that head on because you can bring the provider to the patient as opposed to vice versa. And it helps deal with the national shortage that we're facing in the United States, especially in rural areas with specialists. It's important to realize why this matters too, is that a lot of well-controlled medical studies have been done and show that when you have a specialist taking care of the patient in their specialty field, the outcomes tend to be better. You know, a good example in my field is patients that get Staph aureus bacteremia or blood infection fare better in terms of lower mortality, lower morbidity, lengths of stay, complications, cost of care if they're treated early and by a infectious disease specialist. And that's true in other specialties as well. Let's see, my signal was lost and my screen is refreshing right now. So I'm hoping to, okay, here we go. Okay. So what about the whole issue of telemedicine? Is this accepted by our patients? Is this something that people want? Or is this just a pie in the sky wish? I have to say, I've been doing this for a while now, telehealth, and you know, initially it was designed to help bring specialty care to shortage areas, and that included rural settings. Prior to COVID-19, despite the fact that there were increasing choices out there for telehealth, it was a minority of Americans that had heard of it, much less tried it. In some estimates, only 2%, some maybe as many as 10% had tried it. But with COVID-19, one of the ways that we found we can leverage telehealth technology is to use it to screen patients and see if they've got symptoms where they could be compatible with COVID-19 illness, in which case they could then be referred on to get testing. And let's face it, the test kits have been in short supply. You know, and we didn't want people flocking to centers of care, possibly exposing throngs of people with other health problems to get evaluated for possible COVID-19. So telehealth is a really good way to deal with that because you can rapidly screen people in the safety of their home. They're not bringing their potential contagions into public places and waiting rooms and busy ERs. And so it's a safe way to screen people for the possibility of COVID infection. With all of the fallout from COVID-19 and all of the media coverage and just the way that people are worried about going and exposing themselves, all of this ripple effect, I would say, from COVID. A recent national survey was just completed in April, and they found that now about 60% of survey respondents, and this was over 1,000 American adults around the country in rural and urban areas, said that COVID-19 would make them more likely to use telemedicine in the future because it really got them thinking about some of these advantages. Now, you know, again, this is not my area of expertise, but I've had to track it as a provider because I need to make sure that I'm aware of the changes and how they impact my practice. And so both federal and state regulations are changing, and I would say improving when it comes to the ability to use telehealth and telemedicine effectively. The State Medical Board Federation is continuously updating licensure requirements. This is making it easier for providers to practice across state lines. You know, there still has to be up-to-date information. You don't want to find, as a provider, you don't want to find that you're in violation of any rules or policies. But in general, the trend is that it's becoming much easier to provide care beyond your state's borders as a healthcare provider. The Center for Connected Health Policy is really a great resource. They've got a nationwide presence. They've got regional areas that are aligned with them, and they are really a good resource for telehealth coverage of policies that are and what's happening with compensation and reimbursement, what the rules and regulations are. They track it state by state, and they do a great job. And then Medicare themselves actually has a provider telemedicine toolkit for facilities and for providers that are looking to try to establish a telehealth or a telemedicine program, because the rules are a bit different than traditional care, and they're changing rapidly. So I'd just like to summarize a few of the important changes that have happened recently with the federal COVID-19 response and the rules for telemedicine, and how those are impacting our ability to deliver care using telemedicine in rural areas. With Medicare weighing in now, and with their changes to the healthcare delivery model for telehealth, they've ruled that telemedicine services can now be used in all settings, rural and urban, physician offices, hospitals, nursing homes, rural health clinics, and in the patient's homes. Before, Medicare wouldn't pay in many cases for patients to get telemedicine visits in their homes, but in the advent of COVID-19, they said, well, that's the safest place. In many instances, that's the safest place for a patient to stay, is in their home, rather than potentially bringing their COVID-19 infection into a healthcare setting. Another problem that was responsible for somewhat slow uptake of telemedicine was that providers felt that they might not get paid for delivering the services, and health systems felt that they might not see the reimbursement either. And now there's parity, basically, meaning that telemedicine visits are being reimbursed at the same rate as in-person visits, and that really has been a boon to being able to do telemedicine. In the past, you could do a follow-up visit once you had seen a patient in your office. So if they came in and saw you and you had established a relationship, then you could do some follow-up by telemedicine. But for a patient whom you've never met before, you could not see them for their first visit using telehealth technology, and that's changed. Now you don't have to demonstrate that you've had a prior relationship with this patient for them to seek you out and for you to be able to deliver care to them via telehealth. And as we've seen throughout the years, when Medicare takes the lead on a position or on an issue, a lot of times the state Medicaid agencies, as well as private health insurers, will follow suit. They tend to take their lead from Medicare. Some of you may have heard of the HIPAA waiver in terms of patient protected information. The Department of Health and Human Services has offered guidance that they are going to relax the requirements and the enforcement of some of the HIPAA issues surrounding video platforms like Skype and Zoom. The only criteria that they still are keeping in place is that it can't be a public-facing venue like Vimeo or YouTube, meaning that the public could widely access the visits and grossly compromise the privacy of the patients. But they realize that Zoom or Skype can be hacked, and it's not a rigorously protected HIPAA-compliant platform. But in order to get telehealth to as many individuals as possible in this time of COVID-19, they've said that they're likely not going to aggressively enforce or penalize the use of Skype or Zoom. Now, having said that, my own personal opinion, and I think that the opinion of many experts in the area of health protected information, is that it's still important to protect patient privacy. And if you, everything else being equal, if you have access to a HIPAA-compliant video solution, that's the best way to keep your patient information safe. So just a few lessons from the COVID-19 pandemic. I looked at the American Medical Association. They provide a lot of leadership and guidance at the national level. And their statement is that rapid adoption of telemedicine is a key strategy to limit COVID-19 spread, because it allows patients to communicate with their doctors without leaving their home or their community. It reduces the strain on already overburdened healthcare facilities. So there's a lot of good reasons to look at adopting telemedicine. It safeguards the staff and reduces the demand on personal protective equipment, as I alluded to earlier. But, you know, a lot of times if there's only 2 to 10% of patients have tried telehealth, there can be a strong initial barrier to adopting it or to being willing to give it a try. I see patients' eyes get wide as saucers when I come rolling in on a video cart, or I get carried in on a tablet or a Chromebook into a hospital room, and they have never, if the person has never done telehealth before, the patient initially, they look kind of surprised, but as they get used to the concept and they realize that we're going to have an effective communication session and a good visit, by day 2 or day 3, they're very enthusiastic to see me, and they're like, you know, I'm the talking head coming in on the video screen, and they're happy to see their doctor long distance, and they're happy to have a specialist when they previously didn't have one. But the community needs to be educated that, hey, we're going with telehealth. It's not going to be exactly the same as what you're used to with getting care in your doctor's office, but it's a valuable way to get care and access to specialists. And if all that's explained to them, I think that's going to help them embrace the technology along with the facility. And, you know, let's face it, rural areas do have other challenges like broadband connectivity. I know in my home state here now of Arizona, we're working very hard to roll out broadband internet in areas that don't have it currently so that we can get telehealth and other needed resources to these areas. And so some areas don't, you know, still lag behind, but hopefully as a nation, this is part of the infrastructure that we really need as we go into the future. So as hopefully we'll just continue to see those that connectivity increase and improve. Okay, and my last portion of this talk, I just wanted to talk about what I see as the needs for a successful telehealth program. In my view, telemedicine specialists should be board-certified providers. It would be good if they could dedicate their time to telehealth because, you know, if it's done right, it can be a very all-encompassing activity. In my previous positions, I did telehealth as an additional responsibility, and it was very hard to find the time to do it well with all of the competing demands for my time. Ideally, it's important, I think, if you're working with a facility to become a credentialed part of their medical staff. That improves the camaraderie, the part of being the team. It improves the communication. It allows a higher level of trust with the providers in the community and in the facility. And it allows better accessibility to help guide the staff when needed. And I also think that ideally, a telemedicine specialist should be able to follow patients across the continuum of care. So it's one thing to do a consultation for an acute care hospitalized patient. What happens though when they're discharged and you're trying to do discharge planning, and let's say they're on a course of antibiotics and they haven't completed that course yet, and you want to know that the outcome is good and that the risk of readmission is going to be as low as possible. I think it's important for the specialist to be able to step up and say, I'm willing to work with you in the community, and however that looks, if that's coming back to the private doctor's office and partnering with them, if it's seeing them in the community in their home, if they have broadband internet in their home, if it's even coming back to the hospital, if that's the only place where broadband can be found, and figuring out how to do a follow-up visit there, and what the space might look like and what the staff requirements might look like. I think those are important things that need to be looked at. The technology requirements, ideally you want to have it be an easy platform to use. A web-based platform is helpful so that you don't have a high front-end cost for purchasing software. You need to have access to the high-speed internet connection, as I alluded to. You need to have a webcam and a microphone and speakers. It'd be good if you didn't have to have an expensive video cart. I've seen these robot-type carts that can cost tens of thousands of dollars, or at least $10,000. Whereas, ideally, to make it accessible to as many rural facilities as possible, if you have an iPad or a Chromebook or a laptop, a tablet, for a few $100s or maybe $1,000 at most, you should be able to provide a good level of service. And it's important to have IT support in your facility so that they can troubleshoot if you have problems with connectivity, if the software has glitches and needs to be, looked at, just so that there can be a good, let's face it, this is a technology tool, and you need your IT people to be able to help you with that. So the last thing I wanted to discuss, and then we're going to pivot to the part of the webinar where we can have questions and answers, is a case study. Rural telemedicine case study, and this is actually from my own experiences. We met the challenge head on. We proposed a solution, and then I wanted to explain the results and how things worked out for this facility. There was a rural facility in Colorado that was very busy. and they had a pretty high volume. They were they had recruited successfully to a number of specialties, including they had hospitals, they had general surgeon, they had orthopedic surgery, they had neurosurgery. They had a whole panoply of specialists, but they just really couldn't recruit an infectious disease specialist. Despite being a well-respected facility, a very safe community, a nice place to raise family, they just couldn't find a physician that would settle there and provide boots on the ground infectious disease care. So we approached them and offered virtual care as a short-term solution until they could identify a physician that would be willing to relocate to their community. And immediately, we started seeing improvement in their patient satisfaction scores. The patients were really pleased with the ability to get care in their community. Lengths of stay went down, readmission rates went down. Patients said, I'm really pleased that I can get all of my care here. I'm going to continue to have you be my facility of choice. And the responses were so favorable from the patients, the community, the provider staff, and even the administration and the pharmacy, that now they say, we really don't know what we could have done without telehealth, and we want telemedicine to be part of our long-term vision. And in fact, they've put the whole idea of trying to recruit a full-time position on hold. So our practice is called Nod Specialists, and so that's a little bit of a pun, a nod to rural communities. But now we're a critical part of the team there. We became credentialed members of their physician provider staff. We document our consults and our daily progress notes in the facility's electronic health record. We communicate daily, basically, with their medical staff by cell phone. We use HIPAA-protected text messaging, and we coordinate with the facility's billing office to bill the patient's insurance for the provided services. We've also reached out to the providers in the clinics around the hospital and in post-acute facilities around the hospital, because we know that patient flow goes both ways. Patients get discharged from the hospital and some aren't ready to go home. They go to a skilled nursing facility for inpatient rehab, or they go back to the long-term care facility where they live. And we wanted to be able to follow the patients once they left the acute care setting, and so we've partnered with those facilities as well. And we also see patients in hospital discharge follow-up in their homes when they've got the technology. Now, I didn't want to have this talk just be about COVID, because once COVID comes and goes, and hopefully it will go sooner than later, there's going to be other ongoing and continuing infectious disease concerns. There's going to be the next pandemic after COVID-19, but even just the daily nitty-gritty, there's going to be concerns surrounding infectious diarrhea, C. difficile, MRSA, infection prevention policies, employee health safety issues. Those are all going to be still present, and those really, antibiotic stewardship is a big force right now that rural facilities are having to face, just like urban facilities. We've got a finite number of antibiotics available and increasingly drug-resistant organisms, and if we lose the antibiotics we have, we're really going to be in a difficult situation, not being able to provide life-saving therapy for our patients. So my practice was founded in 2018. We're board-certified infectious disease physicians. We're adding additional subspecialties that are also notoriously hard to recruit to rural areas, like allergy, immunology, nephrology, rheumatology, and endocrinology. We have a custom developed for us. We hired our own software engineers, and it's a web-based software that's easily accessible, easy to use. There's no expensive licensing fees or apps needed. We have made it so that it can work readily on a laptop, a tablet, a Chromebook. Doesn't have high expense for equipment, and we can provide the expertise for antibiotic stewardship. So, of course, our focus is patient care in a facility. We get in and we want to do consultations and follow-ups, but we also can programmatically help with antibiotic stewardship and help assist with expertise, or even run the antibiotic stewardship program for a facility, reducing demand for antibiotics, saving money, and improving patient outcomes. And then we have infection prevention. We have a board-certified infection preventionist full-time on our staff that can lead that kind of expertise as well. So really, I think that, I'm not saying we've got a corner on the market of the right way to do things, but I think we've tried to incorporate a lot of elements into our practice that make us a useful and a value-added partner for rural healthcare delivery and using telemedicine. And I think that, we started all of this before COVID-19. So, it wasn't just a response to COVID-19. We wanted to do this going back to 2018 is when we started, but we now really see the value during the time of COVID-19, and we really feel like it's going to be a continued value-added proposition once we're beyond COVID-19 as well. So that was the end of my prepared remarks, and now I'd like to just be able to turn it back to Terry and keep it open for questions. So thank you very much for your attention.
Yeah. Thank you very much, Dr. Stephan. Boy, I've got a ton of questions here. Also, I'd invite the listeners, if you have a question, put it into the chat box, and we'll make sure that all of the questions are answered, even if we run out of time here. I'm sure Dr. Stephan would be happy to follow up even after the webinar is over. Yeah. There were a number, getting back to this recently published research in Minnesota, where we saw the number of daily telemedicine procedures go from about a little over 1,000 to 15,000. They identified a number of issues and problems. One of them, and I think many of our listeners could put it towards the top of the list, how do you get the physicians on board here? There's some reluctance to bring telemedicine in. So do you have an answer in terms of how do you get physicians more accepting of these types of medicine?
So it's interesting, Terry. I would say it's safe to say there's a splay of opinions, and it's somewhat based on generational issues in my experience. As I'm reaching out, for instance, to try to identify and hire new physicians, I'm finding that the ones that are 3 to 5 years out of their training, they have some experience, but they're not. They're of a younger generation. They grew up with a smartphone in their hands. They're eager to adapt this technology, and they're looking just for an appropriate way to get into telehealth, and they see the promise of it for the future. And I think that so it's an easier sell for me when I'm talking to colleagues. Either if we're going to partner with a facility and provide the specialty care via telemedicine, if I'm talking to young colleagues that are family medicine colleagues or are hospitalists, they're more open to the idea of having their patients receive the care that way and to helping us facilitate that. But I have to say that even the older generation of physicians that maybe it wasn't such a second nature to have technology around, maybe they grudgingly started using a computerized EHR, whatever the case may be, a lot of them, once they see the benefit to their patients, it kind of sells itself. That the technology really becomes less frightening if it's explained and if they can demonstrate and see that it's easy to use and that it's not going to be an impediment to care. A lot of times that really changes minds. And so, there can be some initial pushback. I'm not going to deny that. And so really, but if you can just get people to keep an open mind and demonstrate the advantages to their patients as well as demonstrate that it's not challenging and frightening to use, that goes a long way towards increasing the acceptance.
Yeah. Dr. Stephan, are you seeing patients in their home now, or are you seeing them in a clinic or a hospital setting?
Actually, all of the above. A typical day for me is I have morning rounds in the hospital setting, and those are virtual rounds, and we're licensed in multiple states. So it's pretty easy from my home office. I go get a second cup of coffee, and I can pivot from Colorado to Montana, and then go on to Minnesota. And it's a pretty, and we're licensed in all the states that we practice in. But so I have a daily diet of inpatient consultations, I would say, and then I do outpatients visits as well, and that can be either follow-ups from the hospital, that can be in a skilled nursing facility where I call this facility and the nurse brings the tablet into the patient's room and they're recuperating from a surgery or something like that, and I can do the visit there. Or it can be in their home. Yesterday, right before dinner time, I saw a patient in their home that was a follow-up from a hospital stay with a compartment syndrome and a necrotizing infection, and he had a wound back on, and he's sitting in his home, and his wife was able to put the tablet camera on his leg, and I could do the visit in their own home, and he didn't have to try to figure out how he was going to get into a car and drive to a clinic and walk on crutches with this very painful infection, and he could do it right there in his recliner, his lazy boy, and that was a big boon to him as well.
Yeah, and that's been something I've been extremely concerned about because we now, because of the CARES Act, have the ability, if we're in a rural health clinic, to actually provide care directly into the home. Rural health clinics did not have that capability before. They could have Dr. Stephan, for example, seeing patients in the clinic itself, but because of the CARES Act, we now have the capability of going out and seeing our patients. If we're a primary care physician, we can be using the same technology you're talking about relatively inexpensively and seeing patients in the home. The reason I think that's really important is because we have a whole something called disruptors moving out here. Amazon has very clearly stated that its vision, and it's literally going to put billions behind moving into the healthcare market, where Amazon's going to be providing care directly into the home. And the ability, they're not stopped by any boundaries in that regard. They've got a national goal here. So I've been concerned for some time that Amazon could be seeing patients in rural Nebraska. And one of the issues, obviously, is continuity of care. If Amazon's not coordinating with the local physician, we have some real problems here as well. So I really think that in-home care is going to be a big part of the future, and I think it's extremely important for rural hospitals to figure out a way to get on board here. Do you share my concern, or talk a little bit more?
No, I absolutely do. I think if you want I think a given community in rural Nebraska, okay, they know that community hospital knows the community well. They know they're right there they're embedded in the community. A lot of times the staff live and work, and the kids go to school in the community. They're part of that community, and so that's a natural locus to be able to reach out to the community via telehealth. And I would much rather see that personalized care being delivered by the facility to the community into their homes, as opposed to having a large international corporate impersonal giant come across and do a one-size-fits-all delivery across with a tsunami wave across the country, just overrunning because of their large resources and deep pockets, but not necessarily appreciating the nuanced differences from one community to another, what the patient population is like, what the people need, what they like, what they want, that personal touch that they want. You should be able to have that and still have it be delivered via technology, in my opinion. And I think you can have it the best of both worlds if you do it properly, and if you do it from the rural facility's vantage point, as opposed to having a large corporate entity kind of come through and do a one-size-fits-all care.
Yeah, and we know what happened, and I don't mean to pick on Amazon. I live out in the country, and I order from Amazon all the time, but we know what happened to our local stores as Amazon, the big Walmart superstores, et cetera, come out. And it is inevitable that this is going to happen again. And so that's why it isn't, I don't think rural hospitals all have to develop their own programs here. I'd really encourage them to look to other organizations. Dr. Stephan and NOD specialists are one option, but what's happening is there's going to be more and more of these options out there. And I really liked your advice about choosing one that you feel you can live with, that will partner with you, and also think about that the other, it's not just the big healthcare system down the road. You've now got Amazon. CVS has said pretty much the same thing. They're rolling out 1,500 health hubs that are going to have telehealth. So if you've got a CVS in your town, it's not going to be that many years before they are going to be, unless you partner with them, they're going to be in competition with you on this. So do think about that. If nothing else, I really want to make this point on this webinar. Think about this as something that's probably going to happen. If not sooner, then definitely later, and figure out where your rural hospital is going to fit in there. Another issue that came up was coding and billing. Do you find that it's been difficult for the rural hospitals to get paid for the procedures that they're doing in their hospitals?
No, first of all, there are G codes. There are telehealth-specific codes that are used by telehealth providers. And so, like when I do a new consult, it might be a G0426 or 427, and that's kind of time and complexity related, kind of like standard E&M codes. And then there's the daily follow-up visits, and those are coded as well. There's also an origination fee that the facility can claim. So for their time to have their provider or their nursing staff or whoever is assisting or being the telepresenter on their end, there's a originating site facility fee that can be claimed by the facility. It's a Q code, I think a 3014 or something like that. And so that, the bottom line is, in a busy practice, if I'm seeing 10 patients in the hospital, in one hospital, we go from room to room, and there's a facility originating site fee that can be collected for each of the visits that's being done, as well as the CPT codes specific to telehealth. And so it's really has made it really nice to be able to do the telehealth, because those are codes without modifiers. Those are existing codes that have been put in place for capturing the reimbursement surrounding telehealth care.
Yeah, and it strikes me also that we are seeing in this country a growing need for behavioral health specialists, for folks that can deal with mental health issues. And I think particularly in the COVID-19 era, we're going to see a significant increase in the behavioral health emergencies in that regard. So it strikes me that it's all because of the shortages that we're seeing in psychiatrists and mental health providers. The telepsych in particular is another one that's going to be of huge value here. And when you look, I just got some figures here. Clinical psych cost is about $5,100 or $5,100, while the telepsych consult is like $2,100. So you have any other thoughts on telepsych?
Just I agree with you that it's a specialty that's in high demand and is a shortage. It's, again, outside of rural areas. Most mental health and professionals and psychiatrists are kind of congregated in large urban areas, and so you get out to rural areas, with psychiatry, the needs aren't any less. The stressors, life stressors, and the coping skills aren't any better just because you live in a rural area, and yet the services that you have access to are very limited. And so I think that, again, the more we can leverage telemedicine as a technological tool to get critical shortage specialists to where they need to go. And I can, I think that I've heard about teledentistry, and I've heard about telephysical therapy, and how does that work? Well, they can actually teach the person how to do exercises and then supervise that they're doing them by video, and and that kind of thing. Because again, anything that you can name that might be in short supply in a rural healthcare setting largely can be addressed, unless if it's actually putting a scalpel to somebody's body to remove a diseased organ. I mean, anything that's short of that just about can be done via telemedicine, and can be done effectively. And so I agree with you. Mental health issues are front and center in a lot of people's lives, and a lot of communities, there really are limited to no resources